common reason for lingual perforation is we are not reading the drill. Slowly we have to do it. We have to respect the resistance. If you do blindly, then it will perfect. Many times we have also done perforation. Our old X-ray CBCTs, when we see, the implant will be going like this. Luckily we escaped. Okay. So if you rest, because the bone is not like this. So you hold like this and you drill. The bone is something like this kind of C shape. This is called C shape. There are 4 shapes you can see in the anterior mandible. So these are all the articles which we should read. Pear shape, hourglass shape, these are other shapes. Okay. Once this patient loses the tooth and resorbs, the shape differs, right? Imagine the same patient comes after 30 years. Patient lost, patient was wearing denture. The result will be like this. At the time you can drill straight, no problem. Okay. Of course, this vessel will only come in the midline, madam. Okay, you are seeing this foramen, right? This is only in the midline. If I go in the lateral incisor, this vessel won't come. Okay. Okay. So that inside bony vessel, it is in the midline. So that is why avoid placing implant exactly in the midline, because you may injure the vessel inside the bone. So place implant in the lateral incisor. Okay. And avoid perforating from premolar to premolar lingually. Avoid placing implant in the midline. These are the 2 rules. Don't place implant in the midline. Don't perforate lingually from premolar to premolar or canine to canine. There is one exception to this. You can place implant in the midline. There is some technique is there. Carefully you can do. It's a short implant. Do not go longer. Only if you go longer, only you will injure this. Okay. But it is better to avoid in the initial stage. Why to take care of things. Very easily you can place one implant in the lateral and one implant in the lateral. Quite well. Have you experienced any bleeding lingually during surgery?
Yes, sir.
Which kind of surgery?
During GPR, what I used to do, I used GPR.
Okay.
Guided bundle.
Guided bundle.
So we used to explain both the sides. Like we used to visualize both the thing.
Okay.
And bleeding just comes like that. Next day patient comes with like bluish.
So what is doing is bone building surgeries. So you have to add bone here. So you have to open the flap fully here and fully here. At the time they will be. Now we will see the lateral incisor. See the shape first, as I told. See the outline first. See the outline. Okay. If you follow the root, definitely you will feel the resistance here. Respect it. Okay. But what we are going to do is we are going to do alloplasty here. Okay. Imagine you are going to do alloplasty here for the namesake. Now you can drill straight also. Right? So different things are possible. Whatever it is, during drilling, you just respect the resistance. That's it. Okay. Either this side or this side, whatever it is. So wherever you feel the resistance, stop it and measure it and place the implant, even if it is a 10 mm implant. Okay. Don't think placing longer implant means more success. That is not like this. Placing more number of implant means more success. Even if you place a short implant, if it is good stable, then it is okay. Okay. So if you see, the labial plate is very thin. During extraction itself, it will come out. So definitely till here we may have to do alloplasty. Then how much length we don't know. We'll see. Around 13 something it shows. The bone quality is good. So I am planning for the left side lateral. This is left side lateral incisor. The same kind of C shape. Comparatively here the bone quality is cancellous. Okay. So what is my worry is the lingual plate is very thin. Okay, even the lingual plate is very thin. See the problem, the prosthetic challenge what we get in this patient is, so the tooth is here. Once we do alveoloplasty, we will be placing implant here. Okay, but previously the tooth was here. So we have to give tooth here. So we are interfering with the tongue space here. The patient will be complaining of not tongue is not. So this kind of patients you have to tell them before. Tongue may be difficult to accommodate in the initial stages. Now later the planning is over. Now we are planning for the key tooth. First premolar. This is the real second premolar. Okay. See this same shape is maintaining. Okay. Thin plate, very cancellous bone. Right. We may not get good stability here. It will be very less stable, maybe 30 Newton or 40 Newton from here to here. Around 14 or 16 mm we can place. So we are seeing for the distal root of 6. Okay. Okay. So this is a very important tooth. See the outline. Okay. Here the main anatomy is on the lingual side. This is a molar. Okay. What is the name of this? Yeah, mylohyoid ridge. Okay. This is the deepest point. Okay. This is the deepest point. This you can feel with your finger. This mylohyoid ridge. If you keep the finger, you will feel it. Then slide your finger this slope. This part. Okay. This part. And this is the lingual wall. So this is the standard anatomy on the first molar, second molar. So this is the mylohyoid ridge. This is the lingual wall. This is the this fossa. Okay. So what is the thing is, why I am drawing all this thing is, this is the deepest point, no? Deepest point you draw a line. The inferior alveolar nerve is always below this line. Even if you don't have CPCT, if you understand this, you can avoid nerve injury. So what you do is, keep the finger here, do the drilling, your drill, you will feel the drill tip here, then place the implant. Place the implant, that's it. Okay, this is called lingual cortical engagement. This bone is extremely dense, right? Now I am seeing the mesial root. This is the mesial root of 6. Now see the anatomy. Where is the mylohyoid ridge? It is present but not very prominent. Right? Where is the depression? It is there but not very prominent. So mylohyoid ridge starts in the first molar area for this patient and becomes more prominent in the distal root. When it goes to the second molar, it becomes more prominent. So lingual cortical engagement technique is more easier as you go behind. Okay, I will show the second molar now. This is the second molar area where Madam told we can place implant as the key to the second molar area. Okay. See the mylohyoid ridge. It is more prominent and it is more higher because the mylohyoid ridge, as it goes back, it becomes close to the crest. See, this part becomes more. Lot of area for us to engage. As you see, this is the inferior alveolar canal, which is below the deepest point. Okay. So place implant like this or implant like this, whatever it is. If you see, this bone is good, but internal bone is cancellous. That is what you saw in the anatomy section, some dark area. Okay. So if you place implant only till here, it won't be stable. You have to get support from this cortical bone. So you can place implant like this. If you place implant like this, there is no need for bending. Or place implant like this. Then the abutment will come here. You have to bend after that. These are all the variations we can. Even if you don't have CBCT, you can use your finger to feel the myeloid ridge, feel this depression and do it. So the finger becomes your CBCT. Once you open the flap, cut and open the flap, once you see visually, your eyes becomes a CBCT. Okay. So even if you have the CBCT, but if you don't know how to see, use the finger, use the feel, then there is no use.